Okay, hi, this is Elliot Fishman, and welcome to our CTisus quiz. And hopefully, this third time will be the correct one. Again, they're doing some work on Facebook, so we're going to get started. This is a quiz I do every week on Wednesday, and once a month on Thursday, we actually show you some of the cases. We spend an hour each week going over interesting cases. So let me show you a couple. This is the first case, and I'll show you two parts to the case. On the first set of scans, the patient's spleen is the area in question, of course, and you can see the spleen is enlarged but homogeneous. Okay, and I'm leaving an important part of the history out, but the spleen looks good. Now, a few months later, the patient comes back with severe abdominal pain, and you can see the low density around the splenic borders, right? You can see it on the coronal views, very nicely shown. Now, what is this? I'll tell you the patient has sickle cell disease, and I think sickle thalassemia to be exact. It's not the typical appearance of infarcts, right? Because those are wedge-shaped, typically single or multiple, or it could be global, but this is kind of the rim. The edge is low density, and then you look into the texture of the spleen, into the cortex of the spleen, and you see it's modeled in terms of enhancement. So you're thinking perhaps this is a bleed, there was no trauma, but also bleeds don't give you that low density around the edge and then this unusual enhancement of the tissue. And here's just a few more images. I wanted to show it to you. And again, the low density fluid, red on cinematic rendering. So just a really nice example. So when you talk about sickle cell patients or thalassemia patients, we always think about with small spleens autoinfarction, particularly in sickle cell disease. We also think about infarcts, regardless of the etiology. But when you have this rim-like low density, and then you have this modeled enhancement, you can see it really nicely on the cinematic here. That's when you're dealing with sequestration. Remember, sequestration, large amount of blood cells into the spleen. The spleen basically has a combination of infarction and autolysis. So you have this low density around the rim, this modeled enhancement, and the spleen grows rapidly. Often this can lead to spontaneous splenic rupture. Splenic sequestration could be an acute abdomen type presentation, so a really good example. Now another patient. Here I'm also showing you a spleen, but you see the spleen is low density. If you look around the head of the pancreas, the patient actually has pancreatic cancer and had an attempt at a Whipple's procedure, which was aborted. But look at the spleen. It's almost totally low CT attenuation. Maybe a little bit of capsular enhancement. That's a global appearance. Well, it's not an abscess, not the entire spleen. It's not sequestration, obviously. This is classic for a global splenic infarct or near global splenic infarct. There is some normal enhancing tissue in the lower portion of the spleen. Large spleen, low density, global infarcts, endocarditis, postoperative patient, particularly pancreas or anything that involves the splenic artery, perhaps. Beautiful global infarction. Here it is on the cinematic renderings. Red is low density, is fluid. Global infarction of the spleen. Just a really nice example. So two really nice splenic cases. Let me show you the stomach. I showed this case of a patient with abdominal pain, and what you notice in the stomach, good distension. There's an enhancing lesion about 2 centimeters, let's say, that's very vascular. There it is again. What gives you a vascular lesion in the spleen? In the stomach. If you had a lot of lesions, you could say, and I showed a case a couple weeks ago in conference, a patient with Zollinger-Ellison, with MEN syndrome, where the patients have gastrinomas, and you have all of these hyperplastic polyps or tumors, multiple gastrinomas in the stomach, but here's a solitary lesion. So what can give you a solitary vascular lesion in the stomach? Well, in theory, a neuroendocrine tumor is a good thought. A glomus tumor is a great thought. If you have a history of renal cell or some other vascular lesion, then you could say metastatic renal cell carcinoma, for example, could do it. Pancreatic rests are typically in the antrum, and they can be vascular. You can occasionally get hemangiomas. It's really nicely shown, again, the importance of good gastric distension. There's the enhancing lesion, solitary mass. This was resected, and this was a neuroendocrine tumor. Just a really good case of a primary gastric, approximately 1 to 2 centimeter neuroendocrine tumor. Just a really good example. Okay, another case, patient with GI bleeding. At first glance, you think there's a pancreatic mass, but to be fair, I'm not showing you all of the images, but I'll tell you the pancreas is okay. So when you look at something that looks like pancreas, but it's not, then you're thinking duodenum. And here you see high density, which is active bleeding within the lumen of a mass in the duodenum. So what are you thinking about? Could be lymphoma, possibility. Could be gastric or duodenal adenocarcinoma. Or it could be a GIST tumor. GIST tumors can ulcerate, they can bleed, it's a great location, they can be bulky, they often simulate pancreatic cancer. And this was an ulcerating GIST tumor. Just a very nice example. Remember, at times, big masses in the duodenum, particularly GIST, can really simulate pancreatic adenocarcinoma. All right, let's change to another direction, small bowel colon. When you look at this case in this patient with abdominal pain, look how edematous and thickened the patient's right colon is. You can see it on both the axial, arterial, and on the cinematic views. Really impressively involving the entire right colon, or a significant portion of the right colon, markedly thickened. If the patient was neutropenic, you would think about typhlitis, but now it's involving the entire right colon. The patient also has ascites. You can see some clips here. This patient had pancreatic cancer by history and had it resected previously. So what are we dealing with? You could be thinking about pseudomembranous colitis, patients who've been in the hospital, patients are on antibiotics, they get pseudomembranous colitis. It can be right-sided only, it could be cecal only, it could be a pancolitis. You also talk about the possibility of an infectious colitis beyond pseudomembranous colitis. We also think about ischemia just in general, anyone who's had surgery, but the vessels are all good. There's some collaterals because of the patient's primary tumor. Folds are thickened and enhancing. Again, I probably would have gone with pseudomembranous colitis here, but it's very important to remember, and I showed you maybe some cases online a couple weeks ago about this or last month. When you're dealing with a cancer patient, you always want to think, could this be related to chemotherapy? Here's some more images, the thickening and edema on the cinematic rendering. And this was adenocarcinoma due to colitis secondary to chemotherapy. One of the things I've noticed is that patients at times have colitis that's extremely impressive on the CT, but not so impressive on symptomatically. So it's not always a one-to-one between symptoms and the CT appearance. So that's important to remember. Another case, question of small bowel obstruction. Look at this dilated loop of bowel and some thickening here. So it looks like narrowing, dilatation, narrowing. If you only see the one narrowing on the coronal, you say, aha, this is a carcinoma. But two lesions, that'd be a skip lesion. Here it is again, really nice transition, some wall thickening, mucosal enhancement. What are we dealing with? So again, one lesion alone, I agree with you, I'm thinking about cancer adenocarcinoma. But two lesions, you got to think about strictures. What can give you strictures? Inflammatory bowel disease is one, prior ulcer disease, but that would be a really funny appearance, I would have to admit as well. So what are we dealing with here? Well, again, if you talk about multiple strictures and you don't see any adenopathy, but multiple strictures really makes you think about the possibility of something inflammatory. This was biopsied, and this ended up being a really nice example of Crohn's disease. Crohn's, we typically think about the terminal ileum, but not necessarily. Crohn's disease can be more proximal as well. And this is a wonderful example of Crohn's involving multiple sites in the duodenum as well as jejunum. Okay, let me go to a couple chest, or what I would call vascular cases. Patient was brought in for trauma, and you can see the pelvic fractures. Okay, no big deal. Acetabular, SI joint, no issue. But then, patient having chest pain. Look at the chest. Look at the descending aorta. There's a little flap there. There it is on 3D imaging. This is classic tear, transection almost, of the patient's thoracic aorta. just past the left subclavian, classic location. This patient was very lucky. On the cinematic, you really can appreciate the flaps very clearly. Here it is as I rotate through a few different images. There's no active extravasation. This patient was very lucky and was treated with stents. You want to be very careful when you have MVAs, particularly look at the sternum, look for sternal fractures, because you always want to be careful not to miss the thoracic aortic injury. It's also very good in this case that you can see that it's much easier to see the patient's the section and flap and transection on the 3D rendering as opposed to looking at it on the simple coronal and sagittal views. Just a really nice example. And the routine volume rendering, you see it as well better, but on the cinematic, it was really nicely shown. Now, just to follow up on those, let me show you two other cases. Look at this patient post-trauma. They're intubated, but look at the bleed in the chest, sternal fracture, active contrast extravasation. Okay, here's a few more views. I'll just go through it. Active extravasation nicely on the volume rendering. Beautiful example. Same area transection. This patient was lucky they made it to the hospital. Active bleeding, extensive pneumomediastinum, hemomediastinum. Just a really nice example of thoracic aortic injury due to an MVA just past the left subclavian in the region of the ductus. Just a really nice example. And here it is as I'm showing you a range of different cinematic renderings that nicely show you the process. Okay, really good example. And cinematic rendering very nicely can show you these type of processes. And this patient had fallen out of 3 stories, so they were very lucky. You nicely see on this image the sternal fracture and the vascular injury. You can have vascular injury without sternal fractures, but most of the time you will have a sternal fracture, and if you see a sternal fracture, you better be looking really hard for vascular injury. And here's another one, again, giving you a feel of how these look. Blood around the aorta and the anterior mediastinum, posterior mediastinum, middle mediastinum. Blood is tracking downward, and the sagittal view really nicely showing you the transection. You're not seeing the active bleed as you were in the prior case, but the blood tracks down all the way through the level of the renal arteries. Here it is again on the sagittal view. Just a beautiful example on the volume rendering with grayscale and with color. Again, just a beautiful example of transection. And here it is again, the multiple components, like almost looks like 2 tubes that are broken apart, which is the case if you think about the aorta as a tube. And again, nicely showing you the aortic transection post-MVA. A very nice case. Now let me end this with a couple of kidney cases, patient with hematuria. What you see on the image on the left are tumor masses. Something's infiltrating the peri and pararenal space bilaterally. So it's not the look of a renal cell carcinoma, it's something outside growing in. The first thing I would think about would be lymphoma. Perirenal space involvement, bilateral, very good for lymphoma. There are also nodes present, that's really good for lymphoma. And here's some more images, really extensive, bulky tumor. To me, it's lymphoma. But if I tell you this wasn't lymphoma, a patient also has a clot in the IVC, mesenteric masses. What looks like lymphoma gives you peri and pararenal space involvement, extension into the kidneys, mass in the root of the mesentery. That's going to be melanoma. Melanoma is the most common cause for perirenal involvement when it's not going to be lymphoma. And so just a wonderful case of perirenal spread of melanoma. It's interesting to me when you see lymphoma, particularly when it's extensive, you almost have to say, if it wasn't lymphoma, think about melanoma. And another case looks like a large renal mass, but so much of it is in the para and perirenal space, pushing on the aorta. It could be a large renal mass like a renal cell, but just the involvement of the perirenal tissue takes you away from just a classic renal cell, be it papillary or more likely clear cell, and pushes you more to something like lymphoma. Lymphoma can be bilateral, but it can be unilateral. Beautiful example of infiltration of the peri and pararenal space and involvement of the kidney, and nicely shown in cinematic, in a patient who has B-cell lymphoma. Just a really, really nice example. and something to be aware of. So that was just a great case. So that was a series of cases. I hope you enjoy them. I hope you learned something. And, we're going to have a contest that you could maybe attend our Wednesday sessions for a month or so and participate, or more importantly, just sit back and listen to our faculty go after the cases and really teach you how to think about cases. So with that, have a great day and see you soon. Bye-bye. Hello. You got the wrong number.